Thank you very much, Karen. So I'm not sure I'm going to be able to answer this as well as I'd like to at the present time, but just look at some of the challenges around getting cancer registry data to inform cervical cancer control and planning. So I'm going to really probably just start with giving you a very brief overview of registries. I guess everyone's familiar with the central role of registries in planning and monitoring and evaluating cancer control activities. It's a system of continual data collection done systematically that permits obviously the computation of incidence rates and survival for all malignant tumors, and there are specific standards that we use based on those, predominantly, at least internationally, from the International Association of Cancer Registries, and we serve as the secretariat for that. We have had, in terms of numbers of registries, of course, since Sir Richard Dahl started the compilation of high quality data back in the 1960s, an explosion of cancer registries from 30 plus registries in the 1960s to now close to 350 in around 65 populations. But when we see the extent to which that is in high income versus low income regions, we know there's a lot of work to do in terms of supporting population-based cancer registries. So I'm going to speak a little bit about the impact on COVID, but pre-COVID, there's still quite a lot of things that we need to do to support sustainable development of population-based cancer registries in every country of the world. And this is just a snapshot of the map based on, in essence, high quality data that is included in cancer incidence in 5 continents. Close to 70 countries now have high quality data. And on the other side, it's about 30 countries, particularly in Central Africa, some countries in Western and Eastern Africa too, where we don't have any data at all. But I think it's a very positive map as compared to, say, 10, 15 years ago. There's been a lot of development of networks of registries, particularly in Africa. You can see the yellow where there is actually now population-based cancer registries. Whether they're of high quality yet, it's a process. The challenges are much larger, of course, in transitioning countries. And this is the African Cancer Registry Network. It's been functioning for a few years now. We've only got 2 or 3 population-based cancer registries currently in cancer incidence in 5 continents, but a lot of data coming through from the network. There's a volume called Cancer in Sub-Saharan Africa that's compiling the most recent data, and we expect many registries, hopefully in the years to follow, will be of high quality and to support cancer control and cervical cancer control. And they do give very valuable data. This is a recent paper from our colleagues from the African Cancer Registry Network, just showing you the time trends of cervical cancer. We know, of course, the highest rates are in Eastern Africa, particularly worldwide, but this is looking at Malawi, Zimbabwe, Eastern Cape, which is a relatively rural area of South Africa, and Mauritius, which is a very different population in the Indian Ocean, predominantly Indian population, some thousands of kilometers away from Sub-Saharan Africa, where you see declines. But in the other populations in Malawi, Zimbabwe, and Eastern Cape, we have high rates, and the rates appear to be increasing in all these populations. So this is precious data, but it's also food for thought when we're doing these modeling exercises, and there's so little data, as Karen and other colleagues on this session know, that there's limited data to actually project forward what is going to happen in countries because of this lack of data in many situations. And I'm doing a presentation next week for London Cancer Week and for the Commonwealth, and these are actually the 54 Commonwealth countries, and it's actually a very nice indication of the extent to which the variability in cervical cancer is at the present time. So this is using the recorded cancer registry data to make estimates nationally where we can, and this is included in GlobalCan and what we call the Global Cancer Observatory. But just looking at the mortality, you see Malawi, Zimbabwe, Zambia, they all have population-based data, no mortality data, but we're able to estimate that from incidence and survival. But in any case, a 50-fold variability still just in the Commonwealth countries in the risk here of incidence or death from cervical cancer before the age of 74. So again, and really, Karen spoke about the Cervical Cancer Elimination Initiative. It's been really I mean, aspirational, of course, and its goals, but the fact that the threshold, getting the threshold to 4 per 100,000 women has really motivated, I think, our efforts to really sort of try and position cancer registries as absolutely central to cervical cancer control, HPV-related cancer control, but all types of cancer control. And this is a real opportunity to really show that we need incidence data in different countries. We have here the map of showing the thresholds at 4 and 10, but just looking at the countries in Africa and Southern, Eastern, and Western Africa, you see that the extent to which the rates are way above 10 and sometimes in the 40 to 80 region. So huge efforts required to reduce the burden. And sometimes we're making estimates here where we really should be having incidents that we can continually assess as we scale up the cervical cancer initiative. And that data is used. It's been used by Karen and Kate, our next speaker, in developing these modeling studies of incidents showing the impact of vaccination plus screening, and most recently by Mark Breeson and colleagues in a couple papers around the several types of modeling that we use in the WHO exercise, really showing the potential impact of scale up of vaccine plus screening, and using the global CAN data, of course, based on registry data, to try and at least get a baseline estimate, and then see what happens when you apply these models. We've been working with WHO and many other colleagues to try and position registries as part of a framework for surveillance and monitoring of a scale up of the cervical cancer program. And this is the paper coming out in preventative medicine this year, I guess. We've been working on the elimination strategy chapter in the monitoring and evaluation to try and develop a system that has certainly population-based registries at its core, but it's only part of it. We need to have a specific set of things across vaccination screening, treatment, end of life in terms of specific interventions, and the specific monitoring of programs as we move forward. So we've developed that, and that's coming out in the near future. There's a lot of issues with cancer registries still, and this was from a consultation with Emerald. I mean, aside from the lack of quality, which we're trying to improve, part of that is linked to the lack of sustainability, because often registries are not operational in terms of being part of health planning. They're not funded by governments, as particularly in sub-Saharan Africa, where you have very high cervical cancer rates. The program owners are often hospitals, charity societies, and so forth. So this is a challenge, but these types of challenges, from the availability and quality through to the processes of collection and quality assurance, to the use of the data, to staff turnover, these are commonly problems in transitioning countries, where often it's an underfunded and undervalued pursuit. And this is something we want. For example, the cervical cancer elimination really can actually drive forward progress and make sure that every country in monitoring and evaluating cervical cancer control has a cancer registry at its heart. Really, in the last 10 years, we've tried to assess what we can actually do to take on some of those challenges that you've just seen. And obviously, I mean, our work goes way back 40, 50 years to Callum Muir and Max Parkin, and Max is still very, very, very active in sub-Saharan Africa. But the ideas behind it, of course, are development of site visits, educational programs, train-the-trainer concepts, developing a network of trainers who can be the next generation within regions, within countries, who can train and provide consultancies. We can't all do this in Leon, of course. We can travel post-COVID, of course, and pre-COVID, but we need to actually really address that we need capacity on the ground to be able to do this. And the Global Initiative for Cancer Registry Development, a partnership of many organizations, that's what it's really all about, and developing these what we call regional hubs, and alongside collaborating centers, all centered around training, directed support, and networking. And really, because of the COVID times, we've had to sort of readjust, and we've been working a lot with Viral Strategies and Bloomberg, as well as St. Jude, actually, particularly for childhood cancer, in developing e-learning modules, which will hopefully come out in the spring of next year, developing an evaluation framework in the meantime, so we can also try and assess things online before we can actually go out to registries, which is absolutely critical to our work. And the operating system that often registries use is open source called CanReg, and we're trying to develop improvements in that, including actually developing a module with DHIS, which is an information system that many transitioning countries use, health information system. And if we can get that to speak to CanReg, then hopefully we can improve the data, and we're doing a pilot in Rwanda as we speak. In terms of the global modeling consortium, we're obviously using the registry data and the estimates, and Karen and many other colleagues are really trying to see what we can do with the data that we have to better project, both in the short term and the long term, the impact of COVID. From our part, and just on the COVID impact on the registries, we've developed a survey. This is really part of the consortium, but also the COVID and Cancer Task Force, which Richard Sullivan is chairing at the present time, really trying to look at the impact of the pandemic on registry operations, and also trying to think about contingency plans and what is going to happen in the future, particularly in transitioning countries where obviously the registries are in a more perilous position financially and otherwise. What will happen when these registries potentially cannot work in the same way? So we developed a rapid situation analysis and a survey around May and June of last year. And these are the dark blue are countries affected. The light blue is unaffected. This is based on 214 registries in 91 countries. And perhaps not surprising, but the most impacted in terms of lockdowns and often hospitals being shut, staff being put on other duties related to COVID, registries being shut down, particularly in transitioning countries again. You can see the biggest impact is in Latin America, Caribbean, Africa, and this is what we see when we look at specific registries. That there really was in many registries, such as the registry in Kampala in Uganda, it actually shut for a few weeks, and the prospects of actually getting that data back, getting the data in terms of the medical records, which often can disappear from the main hospitals in these times, it could be a big challenge. I won't go into any details because of the time, but this is ongoing work. We're writing this up at the moment, but the main registry operation issues affected were staff, and of those who were affected, it's about 40% were staff. Staff issues became apparent during the COVID pandemic. Also were affected were financing, and also the data collection itself. And there's a lot more of a breakdown, which I won't go into here, but many cases of reassignment, inadequate working conditions were spoke of, a reduced amount of funding from government, from hospital-based sources, and also access to the data, both in public hospitals, oncology units has also been depleted. So we're trying to follow up what is happening in specific registries, of course, around the world, but certainly it has had an impact in the last months. And this is just from the other side of the spectrum, I guess, a high income example. This is from Sabine Season's group. You may have seen this in Lancet Oncology, and this is just showing that the impact on diagnostic cases in a high income registry, in this case in the National Registry in the Netherlands, is very similar. In Belgium was quite large. I mean, this is potentially something in the order of a 40 to 60% decline during the weeks of the lockdown in the Netherlands. And there are, I guess, a number of factors linked to this. Obviously, one, of course, is individuals not coming for services for fear of disturbing general practices, wasting GP time. Often consultations were transitioned to telehealth, for example. Hospitals have postponed diagnostic evaluation in some indications, for some indications, and screening programs also were partly halted by mid-March. And so this was a process, but at least in the Netherlands, they seem to have found a way to gain these bodies of pathology cases, predominantly managed to accelerate the process and get many of these cases back. We're still in a position where we're trying to work out what is happening in transitioning countries. But the work goes on with the consortium. We're working, for example, in Rwanda and Mexico this week on various activities. Hopefully the effect will be temporary, and we will certainly try and pursue and support registries for cancer control, and of course for the cervical cancer control work as well that's ongoing. So I think that's my last slide. So I'll hand it back to Karen, I think, or is it me?